Well, thank you for asking me to give a talk on broken heart syndrome. Personally, I think this is a fascinating condition, and it is probably the most frequently seen cardiac condition mentioned in the written media over the last couple of years. Well, this is the case scenario that you guys will probably see nowadays. So this is a 55-year-old woman. She was discharged from the hospital recently after an episode of chest pain that was triggered by hearing that her father had died suddenly. She was told she had some sort of heart attack that affected her heart function transiently, but there was no blockages in the blood vessel of the heart. She was a bit concerned because she always thought that heart attacks were due to blockages in the blood vessel. And on the discharge summary, she was told that she had Takotsubo cardiomyopathy. And she was worried that because she knows that cardiomyopathies mean heart muscle problem, and generally it's not a good thing. So she wants to know what is Takotsubo and what it means for her in the future. Well, in the next 15 minutes, I will go through what is Takotsubo, the treatment options, and the outcome for patients with Takotsubo in the short and long term. Takotsubo cardiomyopathy, also known as apical ballooning syndrome or stress-induced transient left ventricular dysfunction, is characterized by acute but rapidly reversible left ventricular systolic dysfunction, and the initial presentation mimics acute coronary syndrome. It frequently occurs in the context of acute stressful life events, and it predominantly affects postmenopausal women. What is Takotsubo? Takotsubo was first described in a Japanese case series in 1991. The condition was named on the basis of the similarities between the appearance of the left ventricle in systole and the round-bottomed, narrow-neck Japanese fishing pot used to trap octopus. This condition has been described in the literature under remarkable different names, including stress or stress-induced cardiomyopathy, apical ballooning syndrome, ampullary-shaped cardiomyopathy, and broken heart syndrome in the context of bereavement. Recently, European Heart Journal has published a consensus document on Takotsubo syndrome because currently there are no guidelines on this condition. The information on my talk will be based on this consensus statement. As mentioned previously, Takotsubo has many pseudonyms. The consensus has therefore recommended using the term Takotsubo syndrome instead of the term Takotsubo cardiomyopathy, because cardiomyopathy implies a primary disease of the cardiac muscle and is usually applied to a primary heart muscle disorder of genetic or unknown origin. Patients with Takotsubo syndrome do not appear to have a primary cardiac muscle disorder, and they do not have any common genetic basis. In addition, full recovery of patients and low rate of major adverse cardiac events at follow-up in reported series in the literature suggests that Takotsubo syndrome is different from the primary cardiomyopathies. There are many different diagnostic criteria described in the literature to diagnose Takotsubo. The Mayo Clinic criteria are the most widely known at the moment, but because of a lack of a worldwide consensus criteria for diagnosing Takotsubo, the consensus statement has recently developed a new international diagnostic guideline criteria to diagnose Takotsubo, and it is called the Inter-TAC diagnostic criteria. There are 8 criteria to diagnose Takotsubo. Firstly, patient will show transient left ventricular dysfunction with distinct regional wall motion abnormalities on echocardiogram. Right ventricle can be involved. The regional wall motion abnormalities usually extend beyond a single coronary artery, but in some cases, the regional wall motion abnormalities can involve only a single coronary artery distribution. Secondly, an emotional, physical, or combined trigger can precede Takotsubo syndrome, but it is not obligatory. Thirdly, neurologic disorder like stroke, seizure, TIA, subarachnoid hemorrhage, as well as pheochromocytoma can serve as a trigger for Takotsubo syndrome. Fourthly, ECG abnormalities like ST elevation, ST depression, T-wave inversion, QTC prolongation can be seen in Takotsubo syndrome, but in some cases there are no ECG abnormalities. Fifthly, the level of cardiac biomarkers like CK and troponin are moderately elevated in most cases of Takotsubo. Significant BNP elevation is common. Significant coronary artery disease is not a contraindication in Takotsubo syndrome, meaning that coronary artery disease and Takotsubo syndrome can coexist. Patients with Takotsubo syndrome do not have any evidence of infectious myocarditis. This is not demonstrated on cardiac MRI, and predominantly postmenopausal women will be affected by this condition. Takotsubo syndrome is estimated to represent about 1 to 2.5% in patients presenting with acute coronary syndrome and in 12% of women presenting with anterior ST elevation MI. Chest pain and shortness of breath are the two most common symptoms seen in Takotsubo syndrome. Pulmonary edema, cardiac arrest, cardiogenic shock, and serious ventricular arrhythmia have been described in Takotsubo syndrome. A unique feature of Takotsubo syndrome is a preceding emotional or physical stressor, although in some cases, precipitant stressors have not been identified. We had published a cohort of 100 patients with Takotsubo in Auckland region, and we found that the presentation was preceded by a physical or emotional stressor in 2/3 of our patients. In the remaining third, there was no identifiable pre-event stressor. The etiology of Takotsubo syndrome is currently unknown. Several hypotheses have been proposed, including multivessel coronary artery spasm, coronary microvascular impairment, and catecholamine toxicity. The reason for the apparent female predisposition for Takotsubo is also unexplained, but may be related to males are biologically better protected against stress-induced cardiotoxicity of catecholamines. Historical evidence suggested that males were exposed to more physical stress than females, and therefore, men might have developed a number of mechanisms protecting them from the negative different effects of stressors. Another postulation is that the adrenergic innervation is different in females and males. The density of adrenergic receptors in the cardiomyocytes is higher in males as compared to females. However, many questions remain on the exact pathophysiological mechanism of this condition, and more studies are required to assess this further. Currently, there is no consensus about the appropriate treatment of patients with Takotsubo. There are no guidelines on the management of patients with Takotsubo because there are no prospective randomized clinical trials on this group of patients. There is a marked increase in prescribing aspirin, beta blocker, ACE inhibitors, and statins on discharge in patients with Takotsubo, which would be consistent with what would be expected to be seen in treatment after an acute coronary syndrome. Beta blockers have been advocated in the treatment of Takotsubo and may be potentially helpful in preventing recurrence, given that beta blockers inhibit the sympathoadrenal system, which is thought to be involved in the pathophysiology of Takotsubo. However, there are only small case series suggesting the efficacy of this strategy, and no randomized clinical trials. Trials with long-term follow-up are required to address the optimal treatment and the duration of treatment in patients with Takotsubo. In general, patients with Takotsubo had a good prognosis with a low mortality rate and a low recurrent rate. However, Takotsubo is not considered a benign condition because of the occurrence of life-threatening complications during the acute phase. The estimated in-hospital mortality rate is about 1.1%. They are prone to get acute heart failure and cardiogenic shock during the acute phase, and left ventricular wall rupture and heart block have also been described during the acute phase. The recurrence is about 2 to 10%. The comprehensive follow-up of 100 patients with Takotsubo at Mayo Clinic showed that the recurrence of Takotsubo is infrequent, and the 4-year survival was similar to that to an age, gender, and race matched population. However, another study demonstrated that the all-cause mortality for Takotsubo was higher compared to an age and gender matched population. The risk of death seemed to be highest in the year following the diagnosis of Takotsubo, and then it decreased considerably in the ensuing years. The death reported in this study were all due to non-cardiac causes, and the recurrence rate was 5%. In 2015, Templin and colleagues published the largest cohort of Takotsubo syndrome patients to date. Their study showed that that there was a substantial increased risk of death and major adverse cardiac and cerebral events in patients with Takotsubo during a follow-up of 10 years. This substantial risk for adverse event in patients with Takotsubo suggests that this may not be a benign disease after all. What about our Takotsubo patient in Auckland region? We recently studied 225 patients with Takotsubo in Auckland region, and we compared them with an age and gender matched ACS cohort and a community cohort without known cardiovascular disease. We showed that the survival of patients with Takotsubo was poorer compared to those without cardiovascular disease, but their survival was better compared to those who survived an acute coronary syndrome. The late death reported in our study were almost always due to non-cardiac causes, and it seemed to be related to the presence of comorbid disease rather than the Takotsubo itself. So how does this result impact on our clinical practice? Patients who survive the initial event of Takotsubo can be reassured that their risk of future cardiovascular death is no higher than the general population without known cardiovascular disease. There is approximately 1 in 20 risk of recurrence in the next 5 years, and they are at a slightly higher risk in the longer term to die of a non-cardiac cause compared to the general population without known cardiovascular disease. In conclusion, Takotsubo syndrome is a fascinating acute reversible heart failure syndrome that is increasingly recognized in modern cardiology practice. The pathophysiological mechanisms involved in this condition are very complex, and they are not completely understood. Current knowledge to guide optimal clinical management is limited, but we can say that the long-term prognosis overall is still favorable. We need randomized clinical trials to identify optimal diagnostic and management strategy for this condition. The potential for national and international registry to collect larger numbers of patients prospectively will aid the understanding of the epidemiology and natural history of this fascinating condition. The International Takotsubo Registry was launched in 2011, and it is an international observational web-based registry, and its focus was to assess the natural profile, different therapeutic strategies, and clinical outcomes of patients with Takotsubo. Middlemore Hospital and Auckland Hospital have been invited to participate in this registry, and we have started to enroll patients into this registry since December last year. And hopefully, we will understand more about this condition in the future. Thank you.
Thanks very much for that, Jen Lee. That was an excellent review of something that we're seeing more and more of and presents challenges. There's a lot of questions, so thanks for sending them in. I mean, one I think is interesting. Is there an ethnic variation?
Sorry?
Is there an ethnic variation?
No, we didn't find any variation in our study at all. So it affects both, whether you are Caucasian, whether you are Maori or Asian, it's still the same.
And I guess I'll be interested to hear your answer to this one. I mean, it's a physiological or psychological stress that triggers the event. Is it more common in people with anxiety disorders? And the sort of the follow-up that goes with that is what sort of, is there any psychological intervention or support available for people after the event? Well,
in 2015, the paper published by Templin actually suggests that patients with Takotsubo do have a higher incidence of neurologic disorder as well as anxiety and depression. So they recommend that besides treating the heart failure during the acute phase, we also need to look into the psychological component of patient. We need to treat the depression, we need to treat the anxiety as well.
And, is there any genetic component to this? Are you aware of any familial
Not that I'm aware
cases?
of, but I know that the Intertech registry, they are doing a study on genetic testing. So they actually, we are not involved in that because of the ethics issue, but those people in Europe, apparently they are having some genetic testing on this. Maybe one day we'll know more about that.
Okay, great.